Hi, good evening, everyone. My name's Sierra, and I'm the marketing coordinator here with RBA. I just wanted to say a quick thank you for hopping on and joining us today for this LGBTQ plus family building webinar. I did want to let you all know that there is a Q&A function, so please feel free to ask questions at any point in time. Just know that all questions will be answered at the conclusion of the event. So without taking any more time, I'm going to go ahead and pass everything off to Dr. Daniel Shapiro.
Hey, everybody. Oh, meeting's being recorded. Okay, great. Welcome to RBA's LGBTQ plus family building. I'm Dan Shapiro. I'm the medical director of the practice and also one of the founders of My Egg Bank North America, which does egg donation. And obviously that's an important part of this story as well. So welcome. We're going to get started. And, why is this not advancing? It's not advancing, Sierra. All right, let's try that. No, that's not working either. All right. No, there we go. Got it. Okay. All right. So we're going to start with the introduction. And this is us. That's me without a beard. We have office locations in Sandy Springs, coming at Piedmont Hospital, right on the campus, in Marietta on the Kennestone campus, and we will be opening in Canton next spring. And we also have a Braselton office, which feeds into Northside Gwinnett. And these are our other physicians. Dr. Toledo is one of the original 5 partners. I came after him. Dr. Sladen after me, Dr. Straub after him, and our newbies, relatively speaking, are Dr. Rubin, Dr. Best, and Dr. Lewis, and Dr. Witt is our urologist. That is a terrible picture of Dr. Naj, who has been on an amazing diet and has lost an enormous amount of weight and is as skinny as all get out. But more importantly, he's a 20-year veteran of the practice, and he has been on the list of 100 scientific authors you have to read before you die. So this is somebody who's really instrumental to how all of this works. One of the techniques that also instrumental in how we do business is a technique known as vitrification, which is a form of rapid freezing. Though he did not invent it, he did make a modification to it about 20 years ago that made it possible, 18 years ago, that made it possible for us to create our egg banking operation and to freeze eggs successfully. So we're very grateful to him. We do IVF, we do general testing, we take care of men in straight and same-sex relationships, we do egg donation, we do gestational surrogacy, egg freezing for fertility preservation, insemination therapy, which would be appropriate for some of our same-sex lady couples, and genetic testing both of patients and their embryos. After you decide you want to proceed, the first step is to get a consult. And so in determining your insurance is very helpful for you in advance, because more and more people actually have some coverages, and some of those coverages do apply in same-sex relationships. So check with your HR and or directly with your insurance carrier. Our business office can also help after you've started with us in explaining what the insurance benefits are. Also a good idea, especially if you've ever done any fertility treatment before, or if you've begun a fertility evaluation, is to get those records so we can review them with you before we make a treatment plan for you. To make an appointment, you go to rbafertility.com. That will take you to centralized scheduling. You register, and then you'll get a contact back to help you pick out a time to schedule. Things that same-sex couples often consider is, since in either arrangement, 2 men or 2 women, something would be missing, either egg in uterus or sperm. A lot of people ask if they can have a family member be their donor. Yes, we do that. It involves some additional expense when it's a directed donor rather than an anonymous donor, but it is important to know that we can do that for you if you'd like. If you would prefer to use an anonymous donor, that's how the consults normally go, either for donor sperm, which comes from an outside sperm bank, or for egg donation, which can come from RBA's My Egg Bank North America, or can come from an agency donor. And we will accept some eggs from outside egg banks as well. It depends on the egg bank. There are some same-sex female couples that will want to do what's called reciprocal IVF, where the egg from one gets inseminated in our lab, and then the resulting embryo gets put into the spouse to carry. Okay. At the initial appointment, a lot of them are online now, so you just log on at the right time. Otherwise, coming a little bit early is a good idea. That way you can meet the front desk, and you might spend a little time with the nursing staff in our small waiting areas while you're waiting to see the physician. When you come, expect that we're going to want to take a very complete history about any prior fertility testing or treatment. We're going to want to know the obvious things. For the women, your age, whether your cycles are normal, had there been any prior pregnancies? If so, do you wish to use the same donor if possible? These are the kinds of things that come up. Obviously, if anyone comes to us with medical or surgical issues, we're going to consider those too when we're making the treatment plan, but very few medical or surgical issues preclude somebody from going forward with fertility treatment. Honestly, we don't do that many pelvic exams anymore, primarily because they don't add much to the information package. If we think that there's a problem with the pelvis that can't be detected by ultrasound, sometimes doing an exam will give us the information we need, but those happen very rarely in the modern era. Also, ultrasound is a better way of seeing what's in there than operator's hand. At that initial visit, we'll determine what additional testing needs to be done. If nothing's been done, then everything has to be done. And the basic workup for fertility is not that difficult to imagine. It's check the eggs, check the sperm, check the plumbing, basically uterus and fallopian tubes, especially if the plan is for IUI. And then all of this egg and sperm sources involved wind up getting what's called carrier screening, which is genetic testing for single diseases like cystic fibrosis, muscular dystrophy. These are the kinds of diseases where you can carry them without having the disease itself. But if you wind up partnering with somebody who also carries that disease, and in this case, it would be if a sperm donor carried the disease, you'd want to make sure the genetic mother did not carry the same disease, and vice versa. If a genetic father carried specific recessive diseases, you'd want to make sure the egg donor that he selects does not carry the same diseases. Because when the egg and the sperm source match up for those diseases, the babies have a 1 in 4 chance of actually getting the disease. There's about 550 diseases that we can screen for. Everybody pretty much carries something, but the finding of both partners carrying the same thing, fortunately, that does not happen that often, though it does happen. After the workup is done, we often meet again to come up with a cycle plan, but sometimes these conversations are so straightforward, we can make up a treatment plan the same day we talk to you for the first time. So for the men, the basic evaluation, if you're going to be a sperm source in a same-sex couple, there's some special considerations here because there has to be a surrogate, obviously, and an egg donor. We get a semen analysis on everybody, but the men have to do something else. They have to do something called a semen freeze with FDA exam. This is one of the exceptions to the physical exam rule. Same is true for women providing eggs that would go into somebody to whom they are not, with whom they are not partnered. The Food and Drug Administration, the FDA, actually oversees this. And the FDA has, and it's my opinion, though I'm not in the minority, most people agree with this, the FDA is discriminatory on this topic. As same-sex male couples probably already know, the FDA banned gay men from donating blood in 1984 during the AIDS crisis. They've since rescinded the blood donation ban, but they did not rescind the sperm donation ban. So what does that mean? It means that you can't be an anonymous sperm donor if you tell the truth and say, yes, I'm married to a man. That's an FDA rule. We think it's discriminatory and ridiculous, but that is the rule. We have to be compliant because they come and they audit us frequently, and we actually can be shut down if we're non-compliant. So the way around that rule is to declare it, because it would be a directed donation. The FDA does not ban a donation from a gay man to a surrogate, technically, if the surrogate knows who he is. That's actually perfectly doable. But there's some documentation that the surrogate has to sign that says she acknowledges that the FDA would not have allowed that to go forward had the situation been anonymous. This is not, the waiver that people sign is not permission to use at-risk sperm. No, everybody gets screened. Nobody carries anything dangerous in terms of the viral diseases that we have to screen for. And we do certify that everybody's healthy before anything's done. But because of the rule, we have to have this form. It's called the known or suspected use waiver. That's the most uncomfortable part of these conversations for me, because I hate making a distinction about anybody that's based on some bureaucratic, frankly, nonsense. But for the time being, it's still the rule and we have to follow it. If the semen analysis is normal or not impaired, is probably the better way to put it, we can usually freeze several straws of sperm from a single sample so that we have multiple opportunities to do IVF inseminations as the process goes forward, because we don't have to get more sperm. Once it's frozen and validated, by the way, and validation requires that the viral infectious blood work be done within a week of the semen collection. And the sperm is frozen while we wait and for the viral testing. If it's all negative, as it almost always is, those specimens are good forever, and they allow us to get around the FDA rule. Okay. And there we go. So for women going through, this is a pretty long list. The real basic evaluation is to check the fallopian tubes if you're planning to do insemination, or if you have any history of tubal factor, which means damage to the tubes. If you know they've been damaged by an infection or prior surgery, we're definitely going to want the X-ray. If you've never been pregnant and you've done IUI 1 or 2 times or whatever, and there's no pregnancy, we're definitely going to want the X-ray. A lot of people do the X-ray up front because it actually has some therapeutic value. We've known since this test was invented about 60 years ago that in the months immediately following the performance of this test, that the pregnancy rate's actually higher than if you had not done the test. And that's because it flushes the fallopian tubes clear of tissue and mucus and any other kind of debris that might be impairing sperm transport. And so the X-ray is a good idea for anybody because of its therapeutic value. Its diagnostic value is what we're really after, but the therapeutic value can't be ignored. We often get ultrasound imaging to check the ovaries and see if we can see the little egg sacs in there. They're called preantral follicles. The higher the number, the better the situation. We also check ovarian reserve with a blood test called AMH, anti-Mullerian hormone. And that would fall under the blood test thing here. Everyone should have a PAP every 3 years if they're in a stable relationship with no prior abnormals. If they've had an abnormal, it depends on the type of abnormal, but they should be followed in those situations by their GYN. Does not prevent you from going forward with an attempted pregnancy unless there's actual malignancy, which is very rare in this age group. We don't really do the basal body temperature testing anymore, and endometrial biopsy for diagnosis is rarely done anymore too. And a postcoital test, that's an 1880s, not even 1980s, but 1880s fertility test, and nobody does it anymore. Okay. For people who know they have a problem inside the uterus, we will often do a test called a hysteroscopy, which is literally a look inside the uterus. If we find polyps, small fibroids, or small bits of scar tissue, the hysteroscope can be used to repair or remove those structures. Okay, so let's talk about donor sperm and donor egg. Lots of sperm banks. We have a preferred list. The reason we have a preferred list is because we know everyone on that list is compliant with FDA without question. The FDA stuff can't be underestimated. Banks that are not religiously compliant, get everybody in trouble, because the way the FDA looks at this is if we accept improperly labeled or improperly collected specimens, even though the bank was at fault, it's on us. And so we have to be real careful about which banks we'll work with. And this is several of the ones we use commonly, but there's more on the list. There's about 10 on the list. An anonymous sperm donor is a donor you don't know from a sperm bank. A directed sperm donor is somebody you know. Now, you may not have known them before you started the process, but if you can name them and know where they live, they count as a directed sperm donor. And all the surrogacies that we do are technically directed sperm donation from one or both of the men in the marriage to the surrogate. The surrogate's considered the reference patient by the FDA and the recipient of the sperm. And both men, even though they're the intended parents, they're considered the donors. But in that example, again, they're directed donors. And so we can use the waiver and get around the FDA regulation. Now, donor egg is way more complicated because the women who donate their eggs have to go through about 2 weeks of injectable fertility drugs. They have to be in our office 4 to 6 times for monitoring. And the egg collection, obviously, is not quite as easy as sperm collection. It requires a minor surgical procedure. It's safe and it's easy, but there can be complications, and not everybody does well with this. And so it's a lot for women to go through egg donation. And we are extremely appreciative of the 21 to 31-year-olds who typically donate for us. My Egg Bank North America is actually a network of frozen donor egg banks. RBA was the first of those frozen donor egg banks, but that we expanded the technology to about 8 other practices. Now it's about 10 practices that are producing eggs for the network. There's about 200 practices that access the bank for eggs, including RBA and the other practices in the Inception Prelude network, which we're part of. People outside our network can access the egg bank, but they have separate relationships with the egg bank outside of our own network. As patients of RBA, you would be entitled to guarantee programs provided by RBA through the egg bank. The success rates from donor egg are quite high. It's about 60% per embryo transfer. And depending on the program that a male couple would select, they could get anywhere from 6 frozen eggs up to all the eggs fresh from a single donor. And of course, there's a wide range in expense, which y'all can discuss with the business office, depending on where you go with that. The basic guarantee program is a promise of 2 good quality embryos. That's the HQE guarantee. HQE stands for high quality embryo, okay, which actually has meaning to our parent society. The HQE says that we're going to give you 6 eggs, use 1 partner sperm per insemination process, and promise a minimum of 2 good quality blastocysts. In that program, we do not promise a baby or a live birth, but if we get the minimum, which is 2, there's about an 80% chance overall that at least 1 baby would result. Most people get 3 embryos, in which case the cumulative likelihood that at least 1 baby would result is about 85 to 90%. So no guarantee with a live birth there, but high rates of overall success. We also have a program called Frozen Egg Advantage, which is a live birth guarantee. The price point's quite a bit higher. That one's closer to $40K. The basic guarantee with 2 high QEs, closer to 20. But in the Frozen Egg Advantage program, you have to qualify for it. Sperm has to be normal, and the uterus of the carrier obviously has to be normal. Because donor egg, that already qualifies out of the gate. But we keep going with as many embryos as we need to transfer over time, 1 at a time though, until a baby's born. If after a while it seems like it's not going to work, we can back people out and give them a partial refund, or they can back out after a certain amount of time if it's not working and get a partial refund. That's a popular program, very popular program. The main reason to use a frozen donor versus a fresh donor, which is important to make the distinction. Frozen cycles usually have a limited number of eggs, but they're much less expensive. Overall, they work the same as fresh, though it might take 1 additional transfer with embryos from frozen eggs to get the pregnancy compared to the rate at which people get them from fresh. The fresh cycle pregnancy rates are slightly higher per transfer than they are for frozen, but only slightly. And the cumulative likelihood of pregnancy is about the same, but you might get to the live birth a little quicker with a fresh egg. Most of the people who choose fresh eggs now are saying we want both partners, both men, to have genetically related kids through the egg donor, in which case we need a lot of eggs. You need about 8 eggs, 6 to 8 eggs per partner to be confident that you'd each get at least one delivery. Ideally 8. 10's better. All of them is the best, but that's pretty expensive. Okay, that's just a basic overview. There's actually so many different guarantee programs that we don't have time to go over all of them, but that would be a conversation that you'd have with the bank. The donors are also screened under the FDA mandate, which means that they can't have any of the excluded viral illnesses either. And they have to be specific age. They can't be more than 15 pounds over their ideal body weight. They have to go through psych testing, and they have to go through genetic screening too, just like the sperm donors do. They also have to have their testing relative to the egg collection within 30 days. So it's a little bit more lax for eggs than it is for sperm, which is 7 days. But it's not difficult to be compliant with FDA is the bottom line. Of the women who apply to be egg donors, about 8 to 10% will qualify. And then they go through ovarian stimulation for about 2 weeks. We collect the eggs and then either inseminate them with sperm right away. That's called a fresh cycle. Or we take the eggs and we freeze them and we post them to our website and say, hey, these eggs are available. And then anybody who's a patient in any of the partner practices or the client practices can then get access to those eggs. So there is not technically a shortage of egg donors, but the eggs deplete almost as quickly as they get collected. And fresh donation, that's assigned to 1 or 2 recipients. So those eggs are all accounted for right at the time of collection. What that translates to is short delays to getting an egg donor. There are eggs available at any given time, but that doesn't mean that the donors that you see will match up to what you want. If you're patient, though, a couple of months usually, the donor that you want or that you'd be happy with usually does show up on the website. You just have to be diligent about checking frequently to make sure that eggs that you might want don't get snatched out from under you. They do go quick. So you do have to, it's a good idea to look every day, frankly. Okay, let's talk now about gestational surrogacy. This is where, by definition with FDA, a woman who is not genetically related to the egg is carrying for the benefit of somebody else. Traditional surrogacy is where the carrier and the egg source are both technically donated. And traditional surrogacy is still frowned upon even where it's legal because it causes all kinds of psychosocial problems, where using the egg of somebody unrelated avoids that for the most part. Most surrogates are found through agencies, and we have lists of agencies that we can refer you to so you can interview or you can find online. We're not big fans of Facebook surrogates because they tend to be a little bit fly by night and not very carefully screened. There are also some very subtle considerations when selecting a surrogate, like, does she have kids on state assistance? That doesn't sound like it should matter, but it does, because by being paid as a surrogate, she may no longer qualify for state assistance and for healthcare for her kids. And yeah, the surrogates get paid a lot, usually between 50 and 70K now, but for their services. But even with being paid like that, very often their kids are still on state assistance. But once they show that in their income, they no longer qualify, and their kids could wind up harmed by being uninsured. And so that's a consideration that we look at. And that happens a lot with the Facebook applicants. The agency donors, that doesn't happen. And that's because the agents typically are careful to find surrogates who either are well insured themselves, or it's clear up front that the intended parents are going to be responsible for providing health insurance for the surrogate and perhaps her family, depending on the social situation. Surrogacy is basically a way of doing IVF and redirecting the embryo to an individual who had no genetic connection to the embryo to begin with, where she's doing it altruistically, but yes, they are compensated as well. Okay. So we have a dedicated team called the third party team at RBA. I oversee that as the medical director. We have about 60 active surrogacy cases right now, and that's pretty typical. So just as soon as some get done, a whole new set come in. And so it's usually about 60 to 70 active cases at any one time. We are one of the largest surrogacy centers in the Southeast, and we work closely with several surrogacy agencies and are happy to screen someone who's not from an agency, though the failure rate in screening is much higher with a non-agency donor and can wind up costing much more in the long run because of the lack of advanced screening. Just something to consider. For two men who are going to use a surrogate, obviously they need an egg donor. The usual sequence of operations is to get the embryos made first. And why would that be so? Because that makes you an attractive intended parent couple for the surrogate. Surrogates want to be able to move along quickly. And so if they sign up with a couple and the embryos aren't even made, they already know they're looking at a 2 to maybe 3 month delay before they get a transfer. If they talk to a couple who already has embryos made, they know that as soon as the workup's done, they can go through. A lot of surrogates have done it before, and so they're experienced and proven fertile. I didn't mention this, but we require that every surrogate have had her own baby at least once, so that she can authentically sign the consent forms that says she really understands what it means to be pregnant, right? Because she's doing it for somebody else. That's an important aspect of this. So again, back to the process. Generally, we have our same-sex male couples pick the egg first, make the embryos first, and then go and find the surrogate. Because having the embryos ready to go it's marketing, but it's good marketing in getting a surrogate. And frankly, though there's not a huge shortage of surrogates, the delays to getting one can be anywhere from 6 to 12 months. And so, again, you want to shorten the time course, be ready to go. Okay. Okay. How do you find a surrogate in Georgia? Well, you don't have to find one in Georgia. They can travel here for embryo transfer. We can even ship embryos to her home, well, not her home, but to a program close to where she lives. And that's especially easy to do if they're part of our network, right? The good news about surrogacy in Georgia is there's no legislation at all, and court precedent, even though we're a very conservative state, favors the intended parents quite well. There's this concept in the law known as pre-birth order, where the lawyers who represent both the surrogate and the intended parents will go to the family court before the baby's born with affidavits from us and from each other that say, yep, we all know this baby is made from egg donor and X partner and Y partner, or however, but not from the surrogate or her husband. And the court looks at the documents, certifies that they're true, and then assigns an order to the hospital to put the two men on the birth certificate without the surrogate or her husband's name ever appearing in the birth certificate. So in Georgia, there's no expedited adoption. There are other states that do this too. Shockingly, Alabama's another one. So in Alabama, surrogacy is not dangerous like maybe South Carolina, where the laws are not quite as favorable, or places like Michigan, where it's not safe at all because the courts there throw out the surrogacy contracts when they're considering a dispute. They don't look at the contracts when they're settling a dispute. It's written into their laws. Recently, New York legalized it, but it was illegal in New York for years because of an infamous case from the 1980s called the Baby M case. It was illegal in New Jersey for the same reason, but it's no longer illegal in New Jersey either. There are other states besides Michigan where the laws are not completely favorable, and your lawyers will know where to avoid attempting surrogacy. Surrogacy is the only choice other than adoption for same-sex male couples. There are some female couples for any number of reasons that would want a surrogate also. Gender dysphoria is one of them. We have some lesbian women who the idea of being pregnant, it's actually quite triggering. And that might be true for both partners, but they want children. And so they both could have eggs collected, make embryos external to their bodies, and then transfer to a surrogate. That doesn't happen much, but it certainly has happened. Surrogacy can be incredibly expensive, and it really depends on your surrogate and where it's done. But in 2023, 2024, from soup to nuts, figure between 130 and 180K, depending on the circumstances. Like I said, very pricey. You can shop it. Not everybody charges exactly the same. And just because one surrogate charges maybe 70,000 and another charges 50, doesn't mean the $70,000 surrogate's a better surrogate. We'll make the medical determinations for you. And then in the end, it's about who you're comfortable proceeding with. When you find a surrogate, you send her records, we review the records, and then we make a determination as to whether we think she's a good candidate. If we don't think she's a good candidate, we're going to say so up front and help you avoid spending agency fees and screening fees for someone who we don't think is going to pass or who we don't think is in the right frame of mind to actually be a GC. We don't exclude a ton of these because the agencies are pretty good at the screening in the modern era, but some do get excluded. And some candidates, after hearing what's involved and really getting it, they decide they don't want to do it. That happens too, just as a warning. Okay, so what are the treatment options if you are in a same-sex female couple? The answer for most is you can start with donor insemination. Now, the sperm comes from FDA certified sperm donors who would be anonymous to you, though, again, you can bring a directed donor, but then they have to go through the FDA screening and the whole bit before we can go forward with the IUIs. There are lots of different ways to order insemination or IUI specimens from these banks. Usually we ask for what's called IUI ready, though you can have raw unwashed frozen sperm, and we'll do the wash, though that adds some expense. This is simple math. If our washing fee, which is about $400 plus the cost of the unwashed specimen, exceeds the cost of a washed specimen from the same bank, take a washed specimen. If it's the other way around, let us wash it. And if it's about the same, go with the washed specimen. Just makes life easier for everybody. Okay, so the key things with donor IUI is to get the timing of ovulation right. And there are lots of ways to do that. A woman could test for her own ovulation by doing what are called urine LH kits or OPKs, ovulation predictor kits. She could take oral medication and do ultrasound and then take a single injection that would time the ovulation. There are other regimens that include more injectable medications, but all of these have the same basic idea. Stimulate the growth of one or more eggs, and then have them ovulate on a schedule so you know when to put the sperm in. Generally speaking, we do the inseminations 36 hours after the trigger shots. And if it's spontaneous ovulation detected by the method we would tell you about, it's the insemination is actually just the next day, not 36 hours later. Okay. So this picture here, I don't know if you guys can see the cursor. This is if you cut somebody in half in the long axis, this is what the IUI syringe looks like. The specimen goes into this catheter, which gets slid up into the middle part of the uterus, and then you just press the plunger. When you do that, the sperm floods the fallopian tubes instantly, and it lives in the tubes for a while, up to 3 to 5 days in almost everybody, and in some even up to a week. So when the egg drops, the sperm's already there. That's the idea. For people with absolutely no problem at all, the expectation of pregnancy, please don't shoot the messenger. It's about 10% per try. Depending on the age of the woman, that's really not that much lower than what Mother Nature would provide. At age 30, it's 20% per month. At 35, it's about 16% per month. At 40, it's about 7% per month chance of pregnancy from sex. And at 44, it's only 1% per month. So 10% sounds low, but it's actually in the ranges that Mother Nature had originally intended. Okay. I don't know if, well, it's working here, so I'm guessing you guys can see it. This is a mock-up of an IUI. And here we go. So here the specimen is the raw specimen is being taken and putting into a centrifuge tube. in very slow motion. And this tube is called a Percol gradient. If there's 7 layers to it, and then you put this into the centrifuge and spin it for X amount of minutes. When you take it out, what's really interesting is the sperm, the live sperm, migrate to layer 3 and 4, and the dead sperm all go right to the bottom. And so then you decant off layer 1 and 2, and you take layer 3 and 4. And then from layer 3 and 4, you centrifuge it again, and then resuspend the sperm in a nutrient media called HAMSF10, which is non-toxic and safe to put directly into the uterus. Once that's been done, the volume's concentrated way down. It's less than a half a cc. And the number of sperm concentrated into that specimen can range anywhere from 10 million to 100 million. We then squirt it in, as you saw before, and the sperm rushes to the tubes. And then when the egg gets there, that's what fertilization looks like. Once fertilization takes place, the embryo will migrate down the tube over the course of 5 days, and then hopefully implant at the end of that 5-day period. Okay? For in vitro, it's a bit different. In vitro, you're taking injectable medications that contain the hormone FSH, follicle stimulating hormone. This hormone tells the ovaries to produce eggs that are sitting in storage to come out and play. The more FSH you take, the more eggs you're going to generate. But there's a limit. Mother Nature only puts up so many candidates per month, and age determines the size of the candidate pool. In a 26-year-old, there's probably 50 candidates vying to be queen of the month. After the queen of the month figures out who she is, declares herself, and starts secreting estrogen, she actually kills off her competitors through the use of estrogen. By producing the estrogen, the lead egg, the queen bee, she shuts off FSH in the brain, and that kills off the other competitors. In an IVF cycle, it's more like youth soccer, where everybody gets a trophy. We're injecting FSH. So even if the lead follicle is trying to shut it off in the brain, we're still injecting it. And so all the other contestants get to wear the tiara and carry the roses. In a very young woman, yeah, you can get 30 to 50 eggs. But a typical yield is between 9 and 15, depending on age. Okay. The eggs are collected from the ovaries after the end of the stimulation period through the vagina. The needle that we use goes right through the back wall of the vagina directly into the ovaries. And the fluid in the sacs in the ovaries, they contain the eggs if they're right. They're floating free in the fluid. So we just have to suck the fluid up. It takes 10, 15 minutes to do a 20-egg retrieval. It's pretty quick. Patient would go home the same day and recover that night, be sore that day. But by the next day, yeah, no, not really. Complication rate's real low, but it's not zero. Biggest complication is bleeding. And, once a year or so, we have a bleeding complication out of 1,500 egg retrievals. That's about the rate at which it happens. Actually, this year we've had 2. Both are fine, but it's not nice in the moment. If somebody's bleeding excessively after an egg retrieval, they get uncomfortable and they can get a little dizzy and anemic. And in some cases, they actually need to be transfused. But again, that's pretty rare. So after the eggs are out, the frozen sperm from one of the 2 male partners, or in the case of a same-sex female couple, their donor sperm, would then be thawed out, one of the straws, and then we inject the eggs. So the eggs are held with a micropipette that you cannot see with the naked eye. It's done with a microscope called a micromanipulator apparatus, and the egg is held by one of the straws coming out of this machine, and then we can pick up a single sperm with the other straw on the other side of the machine. Then you can use the machine to move the straw with the sperm, the needle with the sperm, into the egg, and then you can deposit the sperm in there, and that actually causes normal fertilization. That process is called intracytoplasmic sperm injection, and it yields about a 70% fertilization rate. So in that example, if you had 20 eggs, you'd expect about 14 embryos. But that doesn't mean 14 babies. 14 embryos, again, depending on the age of the egg source, could result in anywhere from 3 to 12 blastocysts, which are day 5 or 6 embryos that look perfect. Those are the embryos we genetically screen if you want to. But in many of the egg donor programs, the testing's irrelevant because it does not improve outcomes, and we actually invalidate the guarantees if patients insist on the testing. There's a lot of misperception about what the testing really does. It's what it really is for. It's not for safety, which is what people think, like to prevent Down syndrome and the like. It does that, but so does Mother Nature do that very effectively. And so what we're really doing is identifying embryos that have no chance at all, because every embryo transfer is one at a time, and they cost about $4,500. So even in a 30-year-old egg donor, 25% of the embryos won't be genetically normal. So let's say an egg donor helps you produce fresh cycle 8 blasts. 2 are predicted to be abnormal. Wouldn't want to spend $4,500 to put either of them in to the surrogate, because 1, it's a waste of time, 2, it's a waste of money, and 3, it's just not going to work. So that's what the testing's for. It's to screen embryos out so you don't waste money on them. Yeah, you get a measure of safety from it, but it's really for efficiency and cost consciousness. And again, this is why many of the programs in the egg bank do not allow testing, because the embryo number is so small, it doesn't make any difference. Either they're normal or they're not, and you're better off just putting them in and leaving them alone. Okay. So the embryos can be frozen even if they came from frozen eggs. And that's how we do most of our cases now. So after the embryo creation cases are over, we typically freeze the resulting blastocysts. And if they've been tested, we wait for the genetic testing, and then we know which ones are normal after the testing is done. And those are the ones that get put up for possible embryo transfer down the road. Okay. This is a not completely accurate 3D model of an egg retrieval. The bright orange lit up ET shiny things those are the egg sacs. This is what the vaginal probe looks like when it's at the back of the vagina. And this is what it looked, well, they started to show the needle sliding through. When it goes through, it does go pop right into the ovary, just like that. And when we turn on the suction, we don't have to pull it off the wall. That's not accurate. It's already floating in the fluid. If they're stuck to the wall, it means that they didn't ripen properly. Okay. And again, about 10 minutes. All right. So that's an egg. This is what an embryo transfer looks like. Oh, no, it doesn't. We have a staff person, Sierra, do we have the video for this? Or maybe we do. There we go. Let's see. No.
I'll look into it. I apologize for that not working, but I will definitely look into it.
Yeah, it's not showing. Basically, what you're looking at here, if you can see the cursor, that's the outer line of the uterus. And this black is urine in the bladder. So the bladder is right next to the uterus. Can't really see the ovaries here, though this is an ovary hiding behind the uterus right here. If this had been an egg retrieval, the vagina ends right here, and in the proper positioning in the operating room, the ovary would be right against the vaginal wall over here. So when we pass the needle through, it's only going about 1 centimeter or 2 centimeters into the patient to get the eggs. If this video were working, this is the cervical canal right here where the cursor is moving. You would actually see the white line of the catheter come in here and move into this space over here. This teardrop-shaped structure is the uterine lining. We follow the growth of that while the patient's on estrogen, which is part of the frozen embryo transfer protocols. And once it's thick enough, it means it's probably receptive and ready to receive the embryo. Then we would slide the catheter to here. The embryologist pushes the plunger. You generally see a little white dot form where the embryo and fluid landed, and then we just pull the catheter out. And then 10 days later, hopefully, the thing will have implanted and you'll have a positive pregnancy test. So I mentioned our lab before. Sitting at the desk in this picture is Dr. Chang. So Dr. Naj is the one who modified the vitrification protocols that made all of this possible. But Dr. Chang's the one who did the research at the University of Connecticut that identified where the weak spots were in the technique because of the potential damage to the eggs. So he's an incredibly talented PhD and knows a lot about the risks of doing vitrification. And we hired him in, I think, 2006, 2007, specifically for that reason, because of his background. The lab has the longest experience of any private lab in the US. We were founded in 1993 as a private practice. We are still technically a private practice. That's distinguished from a university program, which the original IVF centers that are still around we're all university-based. And there's only really about 4 of them. And then comes us. There are other private practices that were founded around the same time, but they're not continuously operating. And so for 40 years, we've been here, over 30,000 babies. We've been serving the LGBTQ community with these services now for well over 15 years. And our egg donor program is actually 30 years old, though the frozen donor egg program dates back to 2006. So our focus in the lab it's really on understanding what people feel when they're going through the process, making sure they really understand what's happening, that they have properly set expectations about outcome, about embryo number, about cost, and about process. The lab also, we built 10 years ago. It's been updated a couple of times in small ways, and we've moved to offsite storage for some of our embryos, which has created more space in the lab as well. But it's been state of the art from the beginning, and it still is. Dr. Naj is also very, very, very fond of a statistic in IVF called the efficiency rating. We have one of the highest efficiency ratings around. It means we get more from less. And we were recently commended by our professional society for being a platinum practice, which means that we're in the top 15% of practices with regard to safety and pregnancy rate. We're the only one in Metro Atlanta who got the designation, by the way. Okay. And so financing, well, it's expensive. So we have loan programs, and we have not exactly discounting, but fixed cost programs. So bundle is the fixed cost program where you know what you're paying up front, and that's it. You buy the program that you want. There's several options. You talk to the bundle people about that. And then there are no hidden expenses for the services after the bundle is paid for. The nice thing about bundle is that they have a group of administrators who will work with you on a case-by-case basis if your circumstances don't exactly fit what the program provides. And they can make some modifications. I can't promise in any given situation, but they told us this when they visited us not too long ago, that, hey, if it just doesn't fit, let them talk to us. We can work something out. Lending Club, they're online. Be careful about the teaser rates. Those are for auto loans. For unsecured fertility loans, it's usually 10, 11%. Capex MD, we've been working with them a long time, same kind of personal services you would get with bundle. And Capex is actually a doctor-financed loan program where there's about 200 practices nationwide, where the physicians all wrote checks to capitalize the bank. And then the bank is at arm's length. We don't have anything to do with the management of the bank or who gets loans. But originally, 20 years ago, there were about 100 of us who wrote checks to finance the bank, and it's been an ongoing concern ever since. We love Capex. They're very personable. So if there are any questions, you can scan the QR code, and you can follow us on social media. The questions you can put in the chat, actually. And I think I'm going to stop sharing so that I can see my chat function. There we go. PowerPoint's over. All right, there's the Q&A. All right. You type your questions in. I'll be happy to answer. Nobody yet. Amazing. Okay, that either means I bored everybody to death and you all fell asleep, or I got the questions answered for you. I hope it's the latter. Since there don't seem to be any questions, let me just say this. You go to the website we mentioned before, or rbaivf.com. There are links there as well that can get you to the third-party program with egg donor or sperm donation/IUI. You can also register through rbaivf.com. Yep. Sierra, anything to add?
No, I do believe our new patient services team will reach out to those who attended just if they had any follow-up questions. So that'll be a good opportunity to ask anything if you forgot today. Otherwise, we are all good to go. Thank you again for those who attended, and we look forward to hopefully chatting with you soon.
Thanks very much, everybody. Appreciate your attending. Have a great day.